Hello, everyone, and thank you for tuning in today. We'll be talking a little bit about why we put this presentation together tonight as a few more people fill into the room. So just so that everyone is aware, this presentation is being recorded. If you wish to change your name to whatever you'd like, you simply need to click on your name and you can rename yourself and preserve your privacy. But otherwise, this meeting is recorded. I'll make an effort to provide this presentation to those who have to leave early. So this presentation came about mainly because my colleagues, Pauline Costa and Carl Tichenet and we have been noticing that while we've been treating women's health conditions for many years, a number of women would present to our clinic, and people with these conditions would present to our clinic, and they would have correlated symptoms of back pain or hip pain that would respond quite well with traditional forms of therapy, physiotherapy, chiropractic, massage, etc., but it would return. And we found that these patients would actually have they had a history of having some of these conditions we're going to cover tonight. I've written the word endometriosis there as a condition, but we will be covering a couple of other conditions that cause chronic pelvic pain. And we found that these patients had no idea that there were viable, effective treatment options available for these kinds of pains. And so our goal tonight is to sort of fill in the knowledge block that's missing, that seems to be missing in testing for and in referring and treating these kinds of conditions so that these people can have improved function. It's only, I would say, the last 3 to 5 years that the University of Ottawa's Faculty of Medicine has invited osteopathic manual practitioners to speak about these kinds of treatments. I would say that prior to 3 to 5 years ago, this was not part of the regular traditional curriculum. And so many of the people who are healthcare practitioners in preceding years, they graduated a while back, they have amazing experience, but they wouldn't have been exposed to this kind of information. So our goal tonight is simply to raise awareness that these conditions can be tested for and treated. I say tested for, that pelvic pain correlated causes can be tested for with osteopathic manual practice. And if anyone has the question about how much of our scope of practice is related to musculoskeletal medicine or visceral manipulation, which is part of our treatment that we do for pelvic pain, about a third of our whole training in osteopathy is related to pelvic pain, abdominal pain, dysfunction of internal organs. So this is a significant part of our practice. And I am very, very pleased to see the people who have tuned in tonight. So thank you for tuning in. I believe you can all hopefully hear my voice and see my screen. Nod, yes. Okay, wonderful. We're going to move along. So in the event you only have 2 minutes to attend this seminar, I'm going to give you the big gist. Tissue stiffness worsens symptoms in chronic pelvic pain. But the good news is that treating stiffness improves symptoms. So generally speaking, the theme of tonight is going to be that stiffness in tissues that support and surround our internal organs, the more stiffness that we have, the more symptoms we typically have. So please, if you wish to share this information or this seminar after we've recorded it, please do so as a whole. We wish not to have it picked apart. So we work as osteopathic manual practitioners, we being Pauline Costa, Carl Tichenet, and myself. We work in tandem collaboratively with patients' healthcare practitioners, be it their gynecologist, their physician, their pelvic floor physiotherapist, or their naturopathic doctor. Our goal is not to replace your healthcare practitioners, just to work with them. And our hope is that we have a greater network and a greater connection between other healthcare practitioners so that we can provide better outcomes and better treatments. So I'll ask Pauline to just introduce herself and say hi.
Hi, everyone. My name is Pauline Costa. I've been an osteopathic manual practitioner for 8 years, practicing for 10 years. Now, 8 years being in this clinic at Ottawa Osteopathy and Sports Therapy. I throughout my practice, I have regularly seen patients come in with pelvic pain, and it has been a subject that has been very interesting for me to get more knowledge about, because I have seen throughout my practice of visceral manipulation and that patients were able to manage more their pain, and also their quality of life was improved. So it's really rewarding to see that. And I'm so excited that you'll be able to see this presentation and get more knowledge about it. If you have any questions, you can email me anytime, and I'll gladly respond to any subject or any questions you would like to have sorry to have information about. Okay.
Thanks, Pauline. We will be making sure that the email for Pauline and Carl are available. Their contact information is available on the website, but I'll ask Carl to say hi.
Hello, everyone. My name is Carl Techenet. I'm an osteopath, and I graduated in France. So one of the areas of my work that I care the most is helping people who suffer from chronic pelvic pain. So I do enjoy working with Richard and Pauline because we share the same, I will say, scientific-based approach. So very interesting.
Great. So as I go along, Carl and Pauline, please do interrupt me if I go astray. If you have comments to make, corrections to make, let me know. You're welcome to just pipe in. And my name is Richard Gregory. I am an osteopathic manual practitioner, like my esteemed colleagues, Pauline and Carl. I am also the clinic owner. So some of my work that I do in the daytime involves doing administrative work as a clinic owner. And as I wear that hat, it means that I spend a little bit less time doing treatment as compared to my colleagues. And I would say that as clinic owner, the topic of speaking and presentations like tonight falls on my plate. So I will be the one doing most of the talking tonight, but Carl and Pauline, please do pipe up if I go astray and you need to make a correction there. I will state that Carl and I are cisgender males, and that as we do not have female reproductive organs, it is impossible for us to fully appreciate what people with these conditions experience, though we do care a great deal about their quality of life and the outcomes from treatments that are provided. So what we lack in female reproductive organs, we make up for with effort and care, I guess you could say. So some learning objectives tonight. We're hopefully going to talk about, we are going to talk about chronic pelvic pain, review some pathophysiology and endometriosis. The other two conditions we're going to talk about tonight are adenomyosis and PCOS. We have a nice mix of people on the call tonight. We have some physicians, we have some people who live with these conditions, we have some healthcare practitioners, some pelvic floor physiotherapists. So I'm hoping to speak to everyone in the room at this point. We have an interest in identifying factors which worsen and improve pain levels. We want to understand the influence of hormone fluctuations on tissue elasticity, understand osteopathic visceral manipulation. That is the term that we use for the treatment that we provide on these conditions. That's one of the treatments we provide. I'll go over some case studies, present the symptoms, treatment, and the outcomes. And we will be reserving some time at the end of the session for questions, and you can write them down if you like, or you can write them in the chat as we go along, but we will be having time for that. Please excuse me and forgive me if I cover some information which you know inherently. I am aware that we're speaking to likely a very well-informed group. So if we present information that you already know, it's just because we're trying to be thorough. So some information about history taking. I think that as patients and as healthcare practitioners, it's really important that we speak comfortably about the conditions and the symptoms that are present with these conditions. So it has to be just as comfortable as saying, I woke up with a sniffle today, or I have stabbing incredible pain with every bowel movement. These two kinds of things, we really have to create an environment that's comfortable for people to be able to speak about all of their symptoms, whether they be bleeding, constipation, clots, pelvic floor pain, or dysfunction. We need to, I think, improve awareness of this. And I think the people on this call already know that, but it's my hope that this message gets pushed along the path. So endometriosis is not fully understood. It's a complex chronic condition where endometrial-like tissues, which normally exist on the inside of the uterus, they do exist on the outside of the uterus, and they can lead to hormone or estrogen-related inflammation. And this is a challenging condition with many different aspects. The pain primarily is cyclical. It occurs in a consistent pattern that varies with the menstrual cycle. Additional types of pain are pain with sexual activity, disabling or increasingly painful menstrual cycles. And when we say painful menstrual cycles, it's whatever's relevant pain for you. If it's high pain for you, it's high pain. Pelvic pain at any time of the cycle, and back or leg pain during menstruation. This is a really key one. Other types of pains are gastrointestinal symptoms, constipation, diarrhea, or cyclical constipation and diarrhea, abdominal bloating, nausea and vomiting, painful bowel movements, and bladder function as well. Bladder function is affected, urinary urgency and frequency, and some pain with urination. Unfortunately, endometriosis can have an impact on fertility, and it can create some difficulty with conception and recurrent pregnancy loss. And I do apologize that I slipped from fertility issues just to fatigue. Not that fatigue is a small problem, but fatigue ends up being the last on the slide. But we have to remember that these conditions are significant, and care and compassion is really important when we're dealing with these conditions. Endometriosis symptoms, the three most common symptoms are dysmenorrhea, so severe pain and abdominal cramping during menstruation, deep dyspareunia, pain with deep penetration or intercourse. Also commonly, there's some vulvodynia. Chronic pain in the pelvis can affect the lower pelvis, the lower back, and hips and other areas. There are 4 stages typically in endometriosis, and the stages are not typically correlated to the symptoms. So sometimes you can have a stage 1 or 2 with some areas of implants or endometriomas, but they have significant pain. And in other cases, you can have stage 3 or 4 endometriosis where there is significant deep infiltrating colorectal endometriomas, and they have minimal pain. So symptoms don't always correlate. So if someone presents with stage 1 or 2 or 4, it's always important to consider that their symptoms are not always related to the stages. So endometriosis, as you can see, affects lots of aspects of quality of life, social life, work life, relationships, mood, sex life, conception, life enjoyment. It's really a whole life form disease. It affects many, many factors. And for that reason, we recommend that practitioners use care and compassion. It's important to note that when we're dealing with endometriosis, people of all sizes, big and small, and anywhere in between can have endometriosis. And body size, whether it's anywhere on that spectrum, does not prevent us from treating chronic pelvic adhesions or pelvic adhesions in endometriosis. So if you do feel like you're having some symptoms, please do speak to your practitioner. Best practices in endometriosis are that the family practitioner, if they have hopefully a family practitioner, it's hard these days, but hopefully that family practitioner recognizes some symptoms of endometriosis and they make a referral to the appropriate specialist if need be. Some people are managed by their family practitioner, and that they initiate all options for treatments. So the research-based recommendations are typically pharmaceutical care or pharmaceutical options, surgical options, pelvic floor physiotherapy, sometimes naturopathic medicine, psychosocial or mindfulness. And one of the reasons why we bring up this presentation tonight is because very rarely is osteopathic treatment mentioned. And it's a big part of what we see. And I would say that of the patients that we do see for women's health, we see some pretty positive outcomes. I'll show you some research on the outcomes and discuss our case studies, but it's hopeful that more people will bring about this topic. So excision surgery, if needed, could be a full or a partial hysterectomy based upon the wishes of the patient in discussion with the physician and specialist. So surgery is not always curative. It does have risks, and endometriomas can return if there are certain cells that are not fully excised. And reliance on surgery as a solution commonly is one of the reasons why there's a long delay in diagnosis, up to 11 years. You'll see that the cases that we present tonight, the age of these patients are in the late 30s to early 40s and even 50s, and sometimes they only get diagnosed in their 40s. So typical diagnosis is done ideally with a transvaginal level 2 ultrasound to identify the endometriomas. It's pretty high accuracy and can rule out other pelvic pathologies. It's not the most pleasant, I am told. So it is now possible to have endometrioma tested for using a saliva sample and a blood sample. There's some great research being done that shows that patterns or signatures in microRNA can identify endometriosis with a 90% accuracy level with just a saliva or a blood sample, which is great. Unfortunately, it's not currently very available. It's only available in private clinics. It does cost about $400. We do suspect that as time goes on and these treatments are more available, the cost of these tests will come down and they'll become more available. Ideally, it would be like buying a like buying a pregnancy test in the pharmacy one day. So much more available, but this is where we are now. So endometriosis management, one of the factors that perpetuates the long delay of endometriosis management is the stigma discussing gynecological symptoms. So I know that I'm speaking to a very well-informed crowd here tonight. Some of the patients that we do speak with, we do our best to make a comfortable environment, but I think we have a bit of work to do as a community providing service for these people, that we need to make this discussion much easier, much more normal, and even in a general public, in media, it has to be less of a stigma. I think it's half the world has female organs, and it's important that we improve on that. One of the tricky parts about diagnosing endometriosis in adolescents is that their pain is often a little bit less cyclic, so it's a little bit more challenging. So healthcare providers should routinely be asking about menstrual cycle, endometriosis-related symptoms, and the impact on their quality of life. And if they don't ask, it is not too much information. Please do bring it up to your healthcare provider. One of the conditions that is commonly associated with chronic pelvic pain is adenomyosis, or the presence of fibroids in the uterus. So this can cause dysmenorrhea, incredible pelvic pain during menstruation. It can cause infertility. It can cause chronic pelvic pain. And it is essentially the growth of endometrial tissue, or tissue that belongs normally on the inside of the uterus. This tissue grows inside the muscular wall of the uterus. It can be on the inside, on the muscular wall, or on the outside of the uterine wall. When these fibroids are on the inside of the lining of the uterus, it causes heavy and prolonged uterine bleeding, which is called menorrhagia. And in worst cases, these patients unfortunately have difficulty leaving their home for multiple days at a time due to the excessive bleeding that they have. So it just underscores the reason why we have to be able to talk about these things and ask the proper questions. Endometrium, essentially in adenomyosis, the endometrium can invade what's called the myometrium, or the muscular wall of the uterus. And when this happens, it can cause a propagation of fibroid development along the wall of the fibroid. So this is a condition that's distinct from, but correlated to, endometriosis. And what's interesting about adenomyosis is that it seems as though a fibroid being present in the uterine wall will create, much like if you have a bruise on the side of your thigh, and that bruise creates a bluish, brownish mark that's larger than the area of contact. We see that a fibroid in the uterine wall will create changes in how that tissue behaves chemically and physiologically in an area that's larger than just the fibroid. So fibroids tend to create fibroids as it goes along. So some of the research I'm showing today, we're trying to show systematic reviews, which is a review of all of the previously available published literature. And so this is a systematic review on adenomyosis. It was done in 2019. So it identifies causative factors for adenomyosis. So why do people develop fibroids? They list external traumatic damage, such as surgical interventions, D&C, a normal pregnancy delivery, or a C-section, and internal traumatic damage, such as mechanical strain or something called myometrial hyperperistalsis, which is essentially when the uterus contracts, instead of the inner lining sloughing off and leaving the body through the vaginal canal, it travels through the fallopian tubes and into the pelvis. And this can cause changes in the way the pelvic function happens. So mechanical forces can be microtrauma, as I've described above. It seems that this microtrauma, or these changes from C-sections and deliveries and surgeries, that they are fundamental regulators of uterus behavior, and they're central to understanding how adenomyosis works. So referral to gynecology is often many months away, which is many menstrual cycles away. What can patients do while they're waiting? So there's a guideline from the Journal of Obstetrics of Gynecology in Canada. They make 16 recommendations. Of these recommendations, 3 of them are for transvaginal ultrasound or an MRI. 2 of them are for medications. 9 of them are for recommendations for surgery, either ablation or embolization, excision, or a hysterectomy. 2 recommendations are made for impaired fertility. But if the patient doesn't want to do medication, which is their choice, and surgery is many months away, in addition to a gynecology referral being many months away, what can the patient do? So there's some really interesting research that's been done on adenomyosis. And again, our theme is tissue stiffness seems to be key to measuring and managing symptoms. So this fancy ultrasound that you see in this picture here, this is an ultrasound elastosonography machine, and it is used typically to assess how stiff a liver is. So in fibrosis of the liver becomes fibrotic and stiff. And so they use an ultrasound machine, much like you'd have in a regular ultrasound machine, but it uses different parameters to measure just how stiff this tissue is. So this study had 57 women with confirmed adenomyosis. So they had multiple fibroids on their uterus. 29 of them had moderate heavy bleeding, so greater than 20, but less than 100 milliliters of bleeding. And 28 of them had heavy bleeding or excessive bleeding greater than 100 milliliters. And so they did this transvaginal ultrasound elastosonography on these patients. And what they found was that they measured 11 different variables that this machine put out that measured how much elasticity is present in the tissue. And they determined that stiffness was associated with chemical changes and correlated with excessive menstrual bleeding. So the more stiff the tissue was, the more these patients had bleeding, and the more they saw changes in chemical function that were not normal. So tissue stiffness, these authors recommended, is key to measuring and managing symptoms. Now, we don't have these fancy ultrasound machines in every clinic, but it is possible to feel these tissues stiffening with manual palpation in healthcare practitioners who have this kind of scope of practice. So adenomyosis, we know that now is stiffness is associated with heavier bleeding, and it seems as though heavier bleeding is associated with stiffness. Stiffness causes changes in tissues, which cause more fibroids, which cause more bleeding. So it's a vicious cycle. And so practice management should try to look at ways to reduce tissue stiffness. This is present both in endometriosis and in adenomyosis. And what we see clinically is that when we treat patients with adenomyosis and they have fibroids in their uterus, we do see that these patients describe to us that they have less bleeding, less clots, they have smaller clots, and they have less number of days with bleeding. I'm going to switch over to the ovary now. And again, this is a systematic review that was done in 2018. They had 3,571 scientific articles, filtered down and excluded the low quality papers down to 122. And the question was, how do physical stresses and mechanical forces affect tissue tension? And how does tissue tension affect ovarian follicle or egg production? This is a very well detailed paper, and you can see the different variables in this diagram of how many different variables they looked at vis-a-vis tissue stiffness. And so the question was, does tissue stiffness impact follicle growth and egg maturation? And I'm sure you can figure out the answer is yes, it does influence it. So their conclusions in this study are unquestionably, the ovary is a dynamic, mechanically responsive structure, and that ovarian rigidity and stiffness appears to play a substantial role in both follicular activation and growth. And so, much like in adenomyosis, we have a vicious circle present. There's a clarity in the research that a stiff ovary produces elevated levels of androgen and progesterone hormone, and that elevated androgen and progesterone hormone presence creates more cysts. More cysts create more stiffness, and the cycle continues. So this has implications for patients who have polycystic ovarian syndrome, or even just 1 or 2 cysts. The more that we have cysts on an ovary, the more that this ovary presents with tissue changes that influence actual hormone changes. So there was an interesting measurement that they did in this study, again, the systematic review in 2018. They found that the stiffer that the ovary is, the harder it is for the mature follicle or the egg to cleave off and leave the ovary. That tissue stiffness actually increases polarity or chemical attraction of the follicle to the ovary itself. And that when you have a stiffer ovary, the follicle cannot leave as easily. It gets attached, stays attached, and you guessed it, it forms a cyst. So less stiffness, question mark, do we get less cysts? We see this clinically in our practice, but I have not yet seen that the correlation to less stiffness giving less cysts is present. This research is sort of still quite recent. It's 2018. I have other information about to present about ovary function, but it's an interesting finding that the stiffer the ovary, that the harder it is for that follicle to leave. So this is a systematic review again done in 2023, and this one looked at implications for fertility. They did, as you can read, that long list of search terms that relate to everything for ovarian function, follicle maturation, signaling in the ovary, and maturations of egg production. And you can see the number of papers they had there. It was 37,368. And of the tests, of the papers they looked at, 89% of them were done in the last 22 years. The overarching theme that was presented in this research was that a healthy ovary that has normal function has normal flexibility, normal stiffness, and that this normal stiffness allowed for normal vascular function, arteries and veins exchanging nutrients, which influence biomechanics, which influences mature function of follicle growth. And that pathological ovaries for PCOS, endometriosis, and polycystic ovarian syndrome, they have stiffer membranes, and they have this stiff membrane affects function, affects biomechanics, and as I mentioned, affects function of hormone production, which creates poor follicle maturation. So for each of the studies that I'm talking about, that we're talking about tonight, the presentation includes the title of these studies, and if you wish to read more, you are welcome to, and I'll happily share, we'll happily share this, this presentation afterwards. So some chronic pelvic pain features. Unfortunately, chronic conventional imaging can't show pain. Many of the people on this talk tonight know that we cannot measure pain with a picture. We have difficulty with that respect, so we have to ask for patient information and patient understanding. It's common to have pain with ovarian cysts, fibroids, infections, history of surgical scarring, adhesions, and frequent bladder emptying and constipation, and that this pain can be constant or episodic. It can be sharp, stabbing, it can be throbbing, radiating, localized, you name it. The people on this talk tonight, I think, know how variable the pain can be. Pelvic pain seems commonly correlated to stiff, tight fascia of the pelvis and the abdomen, and in osteopathic manual therapy, we provide treatment, and it is possible to get treatment to reduce this fascial tightness. And this fascial tightness directly being limited or lowered reduces fascial adhesions and pain. There are 3 ways that pain can be produced in chronic pelvic pain. The first is referred pain from the nerve itself. The second is from local tissue adhesions and tightness, which is what I've been talking about tonight. And the third is central sensitization. And this is where the brain experiences a common signal of pain on a regular basis, on a daily basis. and the brain becomes very effective at listening to this pain. And this is where things like mindfulness can come into play. But tonight's focus is on the second type of nerve pain or pelvic pain, which is local tissue adhesion and tightness. So pelvic, hip, and low back pain can be felt far from the source of the restriction. So in this picture, we have a picture of a woman who's wearing a shirt with a knot in the front, and we commonly will say, if you look at the pleats of the shirt, it can refer along the pathway, and the person wearing this shirt can feel tightness along the area far away from the knot. It's the same for adhesions in the pelvis. They can refer through the pelvis, through the lower back, and through the hip. This pain, if it's related to ovarian cysts, uterine fibroids, and endometriosis, is often cyclical. I'm going to talk about ovarian cysts and endometriomas. Fascia from the ovarian cyst or the ovary itself is very well innervated. So if you stretch this fascia, it gives a pain signal. This fascia has a name. It's called visceral peritoneum. And visceral peritoneum is a lot like saran wrap. It's very flexible, it's very pliable, it's very thin, and it's highly innervated. And if you have a cyst growing on an ovary from an endometrioma, this cyst will stretch this visceral peritoneum, and it will create a signal, which is these little blue lightning bolts, and this becomes a sensitized fascia. So normally people should be able to tolerate wearing a belt, having tight pants, or bending over to tie up our boots. And when there's an endometrioma present, or a cyst, or an element of scarring that's present in the pelvis, it can cause a tightness in the fascia that's so great that people will say, I can't bring my knees to my chest. I can't lie on my left side if there are problems on the left side, etc. So different endometriomas in different locations will give different symptoms. So there's an area called the anterior cul-de-sac, which is where this little yellow star is in the front. This yellow star is currently sitting above the bladder and below the uterus in the front. And this causes bladder pain, pain during urination, and pain in the front of the pelvis. An endometrioma is, again, this tissue that normally belongs on the inside of the uterus, but happens to be on the outside of the uterus and can be in many different locations, but commonly it can be in between these two locations, the bladder and the organ of your uterus. In the posterior cul-de-sac, this endometrioma, or this fascial adhesion, can be present between the descending colon or the sigmoid colon and the rectum and the back part of the uterus. So this causes constipation. This can cause pain during intercourse. It can cause stabbing, incredible pain during bowel movements. Sometimes there is relief after a bowel movement. So moving on to tissue elasticity and hormones. It was a wonderful study that was done in 2019. And this was a study that looked at fascial implications of change in elasticity based on hormone levels, differing hormone levels. So you can see on the top right, there's either stiff, elastic, or very elastic tissues, as noted by these different squiggly lines. And on the left-hand side, on the bottom of the left here, you see a phase where estrogen levels are very high. This is a pregnancy phase where fascial elasticity is impressive. Either manual therapy practitioners or people who work with people who are pregnant can see that they are more flexible and more pliable for very obvious reasons. The second middle column is a low estrogen level, which is a post-menopause level. And you can see that we're missing a lot of those green parallel lines and the squiggly red lines. These are elastin fibers that are unfortunately not present in the post-menopausal phase. And then on the right side, you have the follicular phase, which is essentially tissue homeostasis. This is when we're not pregnant, we're not in post-menopause phase. It's in between, and there's significant changes based on the hormone of the actual structural integrity of these tissues. So hormones. This was one of the first studies that showed that hormones physically alter tissue elasticity by altering their tissue makeup, and it's a really important study. And I think that. In the same way that when we meet patients, we want to know if they're pregnant, or if they're not pregnant, we want to know if they have a fever or not. I think at some point in the future, it should be relevant whether they are in their beginning phase of their cycle, the end phase of their cycle, they're postmenopausal, or if they're menstruating regularly, because it changes what hormones they're experiencing in their body, and it changes their tissue elasticity. So given that hormones influence tissue elasticity, unfortunately, in the postmenopausal state, when we have lower estrogen levels, fascial elasticity is also lower, and it gives increased stiffness. And we put a little sad face on here because it means that a lot of women and a lot of people who have endometriosis are told in the postmenopausal phase, don't worry, your symptoms will be much improved. They are often much improved, but sometimes during this postmenopausal phase, patients will present and they'll have decreased fascial elasticity, and they still have some symptoms of their endometriosis. And what we do find in clinic is that they do have increased areas of stiffness, but this stiffness is treatable. And when we find these areas of stiffness, we do see improvements in function, improvements in elasticity, and decreased symptoms. So the menstrual cycle has implications for decreased estrogen levels. There's a lightish blue or a dark blue line here that represents estrogen as we go along the menstrual cycle. And in the days from 1 to, I would say, 6, there's a fairly low level of estrogen present. We have low levels of estrogen just after ovulation from days 14 to days 18, and then again at days 26. So unsurprising to many of the people on this call, the premenstrual phase is an unpleasant phase with low levels of estrogen, decreased tissue elasticity. And what this means is that decreased elasticity results in more symptoms. And so when we are assessing these patients for function, we do assess. It can be during menstrual flow, it can be at ovulation, it can be in late cycle. It doesn't change what we feel. We still look for changes in elasticity as they're related to symptoms. So this is a picture of the uterus, the fallopian tubes, the ovaries, and the vaginal canal. From the outside, it shows the arteries and the veins. And fascia, it seems, can regulate organ function. As we've seen in the ovary, when tissues are stiff, it does not function as well. So the current opinion is that the organ is an innocent bystander. But there's some new research that shows that fascia can drive disease, and fascia is clearly involved in mechanisms of pain. So this is a 2020 study, and it's describing that fascia changes can influence organ function, artery function, and vein function. So in osteopathy, knowing that the outside of a uterus can be stiff, that the outside of a uterus being stiff, and the uterine wall being stiff influences the amount of healthy function from this tissue. We have a theory in osteopathy that the tissues that we are releasing, that we provide manual therapy to, that these patients come back and they say, I have less bleeding, I have smaller clots, I bleed, I have my menstrual flow or my bleeding is only 3 days or 4 days as opposed to 6 days or 7 days. They often say that they have less breakthrough bleeding throughout the month. And we believe that we're releasing the fascia that's causing a compression on these arteries and veins. And it's possible that by releasing the compression on these veins, we're no longer causing an occlusion of these veins, but yet a free-flowing vein that healthily brings blood flow back to the rest of the body. And so we see that this is one of the areas that we work on when we have adenomyosis and we have restrictions around the fascia. The uterus palpation during adenomyosis is very dense and hard. It's quite a clinically relevant part of our assessment. So I've been talking a lot about fascia testing, and in plain English, what this means is how dense is the fascia? How hard does it feel to our fingers? And how much discomfort does it give the patient when we do our density testing? So what we're looking for is, can we displace the organ? We have a little yellow balloon here representing an organ. This could be a bladder, it could be a uterus. But what we're looking for is, in a specific direction, can I rotate or can I translate this organ back and forth and see which direction is restricted? And what we see is that this kind of testing for density displacement and discomfort often reproduces patients' chief complaint, we say. So their major concern that brought them to the clinic that day is pelvic pain. We see that when we produce our assessment of tissue density, displacement, and discomfort, they say things like, "That's my pain. You reproduce the pain that I only feel when I'm in my premenstrual phase." So density, essentially, we're looking to use our hands to apply a gentle pressure on the tissues themselves. And for displacement, we're looking to create a lateral displacement or a displacement away from the ligamentous attachment in the pelvis. And then we ask the patient, is there discomfort? Or we watch to see if there's an expression of pain, a squinting of the eyes. But these are what we call the 3Ds. So perhaps some of you are familiar already with osteopathy, perhaps not. I'll just describe very briefly what it is. It's a bit of a lesser known profession in Ottawa right now. So in 1874, a traditionally trained medical doctor by the name of Dr. Andrew Taylor Still was practicing in Kirksville, Missouri. He was unhappy with his success rates of his practice. He had unfortunately lost 3 of his children to spinal meningitis, and he closed his practice and created a detailed catalog of manual therapies based on anatomy, physiology, and symptoms, and repeat testing, which is the scientific method. He created this database of manual therapies and started a school of osteopathy, and this became the origin or progression of manual therapy professions such as chiropractic and manipulative physiotherapy. So osteopathy in Canada is, there are 2 kinds of osteopaths or osteopathic manual practitioners. You have medical doctors in the States who have trained in the States. They are doctors that can prescribe medications and perform minor surgeries. There are very few US trained medical doctor osteopaths in Canada. I would say probably less than 7 or less than 10 across the country. All other osteopathic manual practitioners are manual therapists. They do not prescribe medications. They are not physicians, and they obviously do not work in hospitals. But the approach is treating the body as a whole single unit, treating the body as a body that can heal and self-regulate. We are not people who cure things. We simply put the body in a state where the body can do its usual thing and self-regulate. We see that structure and function are inherently interrelated. So structure affects function and function affects structure, as we've seen with endometriosis and PCOS, and that mind and body and spirit are connected. So osteopathy scope of practice is quite large. It's a wide scope of practice. It involves soft tissue massage, joint mobilizations, as you would see in physiotherapy, etc. I've written the letters MSK there. That just means musculoskeletal medicine. So pain of the shoulder, neck, wrist, knee, back, etc. And I have a Venn diagram there that visceral, which means internal organ issues or internal organ function, and cranial. So cranial is headaches, migraine, sinusitis, TMJ, or jaw pain. We see that these 3 systems are in balance, and we strive to reach a balance. And we see commonly in osteopathy that dysfunctions of the viscera can affect the hip function and the lower back function, and vice versa with the cranial system. So much like if you were to see a very holistic healthcare practitioner in any of the healthcare professions in traditional medicine or physiotherapy, you would see that there's a whole picture approach. Our whole picture approach includes assessing function of the fascia that covers the viscera and the organs themselves. So osteopathic visceral manipulation is the term I've been using tonight. It started in France in 1983. There's an osteopath named Jean-Pierre Barral who worked in France. I was going to say France. He was a radiologist who worked in a hospital with a respiratory specialist, and he would do a manipulation of the lung and rib cage, and they would use X-ray, fluoroscopy, and ultrasound to record changes in organ position. And they would compare before and after, and they found significant improvement in function. And ever since 1983, they've increased the database of visceral manipulation protocols and research on these things. And I'm going to present some research very shortly. So some referral resources, if you're ever looking to find an osteopathic manual practitioner, if you're on the call tonight and you wish to find someone who's not in Ottawa, I would encourage you to go to the Ontario Osteopathic Manual Practitioners Association, and that website is listed there. There's a WHO, a World Health Organization, benchmark standard for osteopathy training. It's 4,200 hours, including a minimum of 1,000 hours of supervised training. It's important as a patient or as a practitioner who's referring to osteopathy to ask your practitioner or the people you're referring to or you're consulting about their training, because osteopathy, unfortunately, is not regulated in the province of Ontario, and some unscrupulous schools will give people a piece of paper that lets them practice osteopathy after only 6 months of online video training only, with no in-person exam. It is a concern, it is a problem, and regulation of our profession is being sought. However, in the meantime, please do refer to this list of the Ontario Osteopathic Manual Practitioners Association. All of our practitioners are members of this list and have the required training. So conditions that we treat, there's a list here: endometriosis, dysmenorrhea, menorrhagia, polycystic ovarian syndrome, straight up just plain old constipation or constipation in association with other conditions, chronic pelvic pain, C-section scars, post-operative adhesions, possibly from an infection, adhesions from ectopic pregnancies. If you do have patients who have had ectopic pregnancies, the scarring is typically quite prominent, and they do have significant symptoms from adhesions. They do respond quite well. Partial or full hysterectomies, oophorectomy or a removal of ovary or ovaries, salpingectomy or removal of the fallopian tubes, and appendectomies. So our whole body approach includes treatment in the cranial, visceral, and musculoskeletal system. They are interrelated and they influence each other. So this is a great study that was published just in 2023. They took women and people who had endometriosis with chronic pelvic pain, and they separated 41 women into 21 and 20 people in each group. One half reached the visceral manipulation treatment group, and the other half received a placebo group. They received 30-minute treatments for 4 times over 8 weeks. And the treatment group significantly improved pain intensity, powerlessness, lower back mobility, and physical quality of life immediately after the study, and at 1 and 6 months after treatment. So they were treated over 8 weeks, and after 6 months of post-treatment, they still had significant improvement. Their improvement ranged from 5.43 on 10 on a regular basis down to a 1.62 on 10 on a regular basis, which is a really great outcome. This is kind of the protocol that these authors used. As you can see on the top left, it looks a lot like what you'd see in a manual therapy protocol where people are having their joints mobilized. However, on the top right, you see a treatment that's normally done for lower bladder or uterus. And the bottom left and the bottom second from left are 2 other techniques that are associated with visceral manipulation. I will say that the treatments that are offered in osteopathy are not just pelvis function. They relate to lower back, hip, neck, and cranial function as well when related. So this is another study that was done on polycystic ovarian syndrome, published in 2022. A common recommendation for polycystic ovarian syndrome is a low-calorie diet, a little bit unpleasant, but the diet recommendation being a low-calorie diet has shown in the research to improve symptoms. And so this study looked at low-calorie diet alone or low-calorie diet with visceral manipulation. And as you can see, there's an improvement with the visceral manipulation. They had 30 women in their study, separated into 2 groups of 15, and there was a statistically significant improvement in patients who received the visceral manipulation. We placed a triangle on the top right of the screen there, and on the bottom of this triangle, you would have case studies, so We treated Sally. Sally had this protocol. Sally got better. It's a case study of one. This is a high risk of bias and a low quality study. The study that we're showing tonight is on the top part. It's a randomized controlled clinical trial. It's one of the most reliable studies that you can have that look for correlations between symptoms and outcomes. And so many of the studies that we're going to show tonight, or we are showing, are of this higher quality. So a long-term study that was done on connective tissue manipulation in women with primary dysmenorrhea, so very painful, very dysfunctional menstrual cycles, was done. It was published in 2023. This is 35 women, 18 women treated between 2 cycles and 17 treated for 3 cycles. So either 2 menstrual cycles or 3 menstrual cycles. And they wanted to see how long the improvement lasts. And so the authors concluded that significant decrease in pain severity was found, decrease in fatigue in both groups, and they had a sustained improvement at the 3rd and the 6th month and the 12th month after follow-up. So they had 3 cycles of treatments, and 12 months after this treatment stopped, they still had a significant improvement in function. And that p-value, p.0001, is a really high reliable factor. So some nice long-lasting changes there. So this is, again, a systematic review. This is a review that was done 2 times in 2018, and it was repeated again in 2022. And the 2022 looked at the role of osteopathic care in gynecology and obstetrics. And what they were looking at is the effectiveness of osteopathic manual therapy in gynecology and obstetrics. They looked at 131 full-text articles comprising 2,632 patients. And what they found was that effectiveness of osteopathic care in gynecology and obstetrics was present, and osteopathic care was considered safe and a complementary approach to traditional gynecological care. Again, we're stating here that we are complementary as practitioners in osteopathy. We do not replace your other healthcare specialists that you're seeing, be they physician-based or paramedical healthcare practitioners. We simply are complementary. So this is a picture of the common hand positions that we see in treatment when we're assessing displacement, density, and discomfort.
Rich,
And we're
can
looking.
I add a little note into that?
Oh, please, yes.
Yes, because I see on the pictures that just the hands, they apply quite a lot of pressure, which is just to show how we're doing the technique. But it's important to just approach with a gentle pressure, like you mentioned before, like a gentle pressure in the area, just because they can be quite sensitive to pressure, patients with pelvic pain. So I would just say just go more superficially first and see how the patient reacts, so see their faces as well, because it can be quite painful.
Thank you very much. Yes. So we compile these pictures, but as Pauline mentioned, the sensitivity of the tissues can be quite high. So as she mentioned, progressive. Thanks for that note there, Pauline. So other healthcare practitioners, if you are a physician on this call, or if you're a naturopathic doctor or a pelvic floor physiotherapist, we do encourage an abdominal assessment, and that abdominal assessment be modified to include directional testing for displacement, density testing. Does this feel like a hard avocado to you? Or does it feel like a very, very soft, overly ripe banana? Or something even softer, like a semi-inflated balloon. So the tissues change in density quite significantly. And the same as it's easy for us to tell if a noodle is al dente or overcooked, your hands will get very used to feeling if something is overly dense and the patient says that's painful, or if things are soft and supple and mobile. So this is a position that we often have our hands in for testing for constipation. It's the ascending colon. And then we have another area on the other side, which is again for constipation and pelvic pain. This is the descending colon. And what we often see is that when we're treating these patients, that the hypersensitivity of the pain when we palpate gets significantly reduced within 2 to 4 minutes of the treatment protocols we use, and patients can often feel it themselves. This is a hand position that's used to assess the bladder and the uterus. And it is important to note that if there is an IUD present, that this is a contraindication for direct uterus manipulation.
May I say something, Rich, about the IUD? So,
Please, yes.
for sure, it's a contraindications, but as you showed on the previous pictures, we can also work on the lateral side and on the flank of the abdomen also. So we are very careful about the IUD, and we also make sure person we are be in without pain during the treatment.
Thank you.
Yeah.
Yeah, so it's a contraindication for direct manipulation of the uterus, but as Carl mentioned, we're still able to work the lateral aspects of the ligaments that support this. This is another common test that we use to determine if there is restrictions or adhesions between fibroids and the bladder. And many patients who have fibroids on the front of the bladder can cause compression on the, fibroids on the front of the uterus. This can cause pressure if this fibroid is pressing on the bladder, and you can have an adhesion between the two. When you release the adhesion, they see a significant improvement. So some practice recommendations are that we co-treat with other practitioners, whether they be physicians, gynecologists, or other healthcare practitioners, such as pelvic floor physiotherapists and osteopathy, and that we have a team-based approach. And some outcomes are that symptoms and stages vary significantly, and that each person has different symptoms. And we often see changes in patients within 2 to 4 treatments, but it varies from person to person. And some follow-up is required typically afterwards, somewhere between 2 and 4 times a year. Some patients come in more frequently, some patients come in once a year, just as maintenance. And a note that medical doctor involvement and gynecologist management is the gold standard. We do not diagnose, we are not physicians, and we rely on physicians for that purpose. So I would like to go over some case studies. So this is the first case study. This is a patient who presented at age 43. They were diagnosed with endometriosis based on symptoms, which is late. They were diagnosed at 43. They had a hysteroscopy. The uterus had multiple polyps. Symptoms were searing, stabbing, incredible pain at lower pelvis, incredible stabbing pain in her rectum before and during bowel movements, like giving birth, bloating and stomach pain immediately after meals, and searing pain across her upper abdomen, which wake her from sleep. She had abnormal bleeding so bad that she could not leave her house multiple days a week. Her pain was present intermittently on and off during her menstrual cycle and was always worse during the end of her cycle, days 1 through 4 of her cycle. She was unable to attend work many days of the year and unable to attend social functions, and her 7-year-old daughter wanted to sit on her stomach, and this was a real no-go for her. So her gynecologist plan was suggested an excision surgery with partial or full hysterectomy, depending on the severity, IUD with hormones, and she did have polyps removed. The bleeding did persist despite removing the polyps. The patient opted for surgery, but not to have the IUD. And so our osteopathic exam showed that she had a stiff lower torso. She had pelvic visceral area showing multiple areas of increased density. And we saw that there was a specific density in the lower pelvis on the right side of the bladder and the upper abdomen. In the same way that a traditional healthcare practitioner can assess a knee separate from a hip, it's quite commonplace for osteopathic manual practitioners to assess bladder separate from assessing the uterus, separate from assessing the ascending or descending colon. So this patient received 4 treatments in osteopathy, including visceral manipulation. She was treated for 60-minute appointments each time. The outcomes were that she had very, very little pain at her rectum before and during her days of her period. She had much less lower cyclical pelvic pain. Her heavy bleeding did persist. It was addressed on 2 of the 4 treatments, and her searing pain across her abdomen remained unchanged, but she did see some significant improvement in bowel function. That patient did have a full hysterectomy at 1 year after the end of her treatments, and she was very happy with her outcome. Case study number 2, at age 38, this patient was diagnosed with endometriosis. This patient underwent 5 rounds of IVF. The IVF rounds were unfortunately unsuccessful, and they significantly increased her endometriosis symptoms. She had a laparoscopy to remove her left ovarian cyst, which was the size of a softball. Hysterectomy was performed, but the right ovary was preserved. So her operative findings were that the sigmoid, which is the descending colon, was adherent to her pelvic sidewall and her left fallopian tube and her left ovary. Additional adhesions were present in her surgical report. Her pre-hysterectomy symptoms prior to her surgery were 7 to 10 days of extreme pain, heavy bleeding, and pain with intercourse, and pain with bowel movements. Post-surgery, she had much less pain. But 2 years post-hysterectomy, post-surgery, she developed right side low back, gluteal or bum, hip, and groin pain on a daily basis. This patient happened to be a physical education teacher. This was a burning toothache-like pain that was 4 to 5 on 10 every day, all day, and it persisted for 4 years after her surgery. Her treatment in physiotherapy and massage was helpful to give relief for 2 days, and then her pain returned to baseline 4 to 5 on 10. X-rays and her physician exam were normal. Her osteopathic exam showed pelvic viscera, multiple areas of tightness and increased density, reduced mobility, so the 3Ds, and a hypersensitivity across the entire right lower pelvis and ascending colon. She had a stiff lumbar spine and poor flexibility in her right hip. So this patient received 4 treatments of visceral manipulation for 60 minutes apiece. And the outcome after treatment 1 was no change. We had about 10 minutes of treatment on that first appointment. Her treatment number 2, she had 48 hours after her second treatment. She had no pain in her lower back, no pain at her hip, and no pain in her groin, which is quite a big change after the previous 4 years of pain. After 3 treatments, she had still no burning, no toothache pain in her lower back, her hip, or her groin, and she had a return of mild intermittent hip pain that she could manage with stretching. And after treatment 4, she had returned to soccer and basketball, and she had good function in her pain. So this patient was followed up after 5 years. She receives 45-minute osteopathy appointments every 2 to 4 months, and she still develops mild right hip sensitivity, but her 4 or 5 on 10 pain is essentially no longer present. Case study number 3. Age 52, this patient was diagnosed with adenomyosis or endometrial tissue in the uterine wall. Her ultrasound showed a uterus the size of a 16-week pregnant uterus. However, she was not pregnant. She had 2 intramural phagotype 4 uterine fibroids, so they were within the uterine muscular wall. And she had a simple right ovarian cyst, 48 millimeters by 38 millimeters. Her symptoms were described as horrible cramping in her pelvis, days 1 to 3 of her menstrual cycle. Most recent cramps caused her to stay in her bed in a fetal position for 3 days. She had 5 years of this incredible bleeding and had to change her pad 3 to 4 times per night, so very poor sleep. She couldn't leave her home for days at a time and decreasing effectiveness with medication. She required iron infusions due to anemia, and she had bleeding multiple times through the month, and her bowel movements were only 1 every 1 to 2 days with very high fiber intake. So she needed to go on anticoagulants for a heart condition, and her gynecologist suggested an IUD with hormones until full hysterectomy, and the patient opted not to get the IUD, but she did agree to the surgery in 3 months. So this patient was being seen for knee pain and had no idea that osteopathic treatments could address elements of adenomyosis. And so we did an assessment, and pelvic viscera showed multiple areas of increased density, reduced mobility, and hypersensitivity over her uterus and her right pelvis near her ovary. She received only 2 treatments in osteopathy, including visceral manipulation. Both were only 45-minute appointments. We were a bit pressed for time. And so you can appreciate that in the 45 minutes, there's some history taking, some assessment, and a little bit of treatment in there. But essentially, after 2 treatments, her outcome was that she had no bleeding between cycles for 2 menstrual cycles, and she had light bleeding only on days 1 to 4 of her cycle. She had no cramping, and she had bowel movements 2 times a day, and only mild need for fiber intake. So she described almost no cramping, and her bowel movements remained 1 to 2 times per day as she went along. She did continue to get her full hysterectomy, and again was very happy with her outcome. So her heavy bleeding did return with a shorter 3-week cycle duration as time went on towards her surgery. We suspect that she would have had improved outcomes with perhaps a third or a fourth treatment, but we didn't have that, so we can't say that for certain. I would say that these are interesting cases, but not everyone, what's the word I'm looking for, responds in the same way. So this is our fourth case study, a 38-year-old female diagnosed with polycystic ovarian syndrome. Her ultrasound showed right and left dermoid and simple cysts, the size between 4 and 10 centimeters. She had 4 laparoscopic surgeries. She had a right side fallopian tube that was adherent and an ovary that was adherent to her pelvic side wall. Symptoms, this is of course according to the surgical report. Her symptoms were 5 years of 4 to 6 on 10, right lower pelvic pain daily, with pain radiating into the upper thigh, and it was unchanged after her laparoscopic surgeries. She could only walk at a very slow pace. That normal walking pace increased her symptoms, and she was unable to sleep on her right side, completely intolerant of bringing her knees to her chest or tolerating any pressure on her lower pelvis, such as belts. Her gynecologist plan was to do repeat observation of ultrasound with suggested medications for her pain. The medications affected her cognition, and she had a very demanding cognitive job, and she just did not find she was able to take her medications. And so she was unable to find, unfortunately, relief with massage, physiotherapy, acupuncture, and mindfulness. So this patient had seen multiple practitioners multiple times. Her osteopathic exam was that, again, pelvic viscera, multiple areas in the right lower pelvis had reduced mobility, increased density, and high sensitivity. She received 4 treatments of 1 60-minute appointment and 3 45-minute appointments. And the outcome was that after 1 treatment, she had entire days without noticing her pain, and she could lie on her right side to fall asleep, but the pain came back briefly after that. While sleeping, that is. After her second treatment, she had continued improvements with less pain and less intense, frequent sensation of pain. After her third treatment, she felt full days without noticing her pain. She had no more right hip pain, and she was doing home visceral manipulation on her own. So we teach people to perform their own treatments and how to feel these changes. And after her fourth treatment, she had 2 weeks without pain, and she was only doing the home visceral manipulation 2 times a week for 4 to 5 minutes. We followed up with this patient at the 3-year mark, and she received no additional treatment in 3 years, and she remained pain-free. So conditions we treat, the summary of the conditions we treat are here. I've covered most of them. We've been speaking a lot about pelvic pain, scarring, dysmenorrhea, adenomyosis, endometriosis. A lot of our patients do also consult for the usual things that you would find, such as hip pain, back pain, neck pain, headaches, and shoulder pain. When we do co-treat with other healthcare practitioners, be it a physician or a pelvic floor physiotherapist, it's really important that we have a team approach and we value the insight that other practitioners provide for us, and we work in tandem to provide improved outcomes. So again, these are our 3 osteopathic healthcare practitioners who have interest in women's health. Thanks to Paulina and Carl for the little bits that you'd mentioned that I had missed. I appreciate your insight on that one. If you have any questions, you're welcome to raise your hand or perhaps put them in the chat. You can always email us at info@ottawaosteopath.com. We are here if you have any questions. Thank you for tuning in and putting up with my sometimes speedy speech. Any questions tonight? Quiet room. How low calorie was the diet for PCOS? I do not have that information. I would guess it was probably less than 1,500 thereabouts, but I would have to get back to you on that. I'm happy to write back to you if you wish to have that information, or perhaps if one of the physicians on this talk knows the answer to that low calorie diet for PCOS. As I'm not a physician, we don't manage caloric restriction or medications. I will say that the patients who are treated for PCOS, when we discuss this as a team, Carl and Pauline and I, we see that the changes that come from visceral manipulation typically are significant with PCOS, and it is more effective than, say, the outcomes from endometriosis. Endometriosis, we have nice changes in treatment outcomes, but PCOS, we see significant changes. So the question, what is the best way for us to recommend people look into this treatment as non-medical folks? So we do have a URL, a web page that we've created on our web page. Our web page is listed there on the screen. It's ottawaosteopath.com. You're welcome to refer them to the website. And on our website, we do have a link for services. And under services, you can look at women's health conditions or women's healthcare. And that describes what we do and our patient intake system. So when patients call at the reception, that we do triage to see who is best for that patient. Another comment here, studies on PCOS show positive results with reduced caloric intake from what they're consuming in order to get gradual weight loss. It's not about the type of diet or a specific number of calories. Thank you, Andrea Prue. I appreciate that intake. Marie-Pierre, what is the difference between pelvic floor therapies, manual manipulation versus osteopathy? That is an excellent question. So I'm not a pelvic floor physiotherapist, so I can't speak about all of their scope of practice, but I would say that osteopathic manual therapy is an external therapy that's applied. There is no internal technique. Traditionally, pelvic floor physiotherapists, as I understand, it's an internal exam, an intravaginal exam, and an intrarectal exam or intraanal exam. And pelvic floor physiotherapists have specific license to perform reserved acts. Osteopathic manual practitioners perform manual therapy to the pelvis, as shown in the pictures, through the abdomen, the lower pelvis, the lower back, the hips. And it's different from pelvic floor physio in the sense that it is not internal. And I know that pelvic floor physiotherapists are very holistic in their approach. They do much more than just internal treatment techniques. But the biggest change would be, I think, that visceral manipulation, as it's been described tonight, is historically originating in osteopathy and falls within the scope of practice of osteopathy. Though my understanding is that some pelvic floor physiotherapists are learning to do assessments and to screen for adhesions in the pelvis. Good questions. Any other questions from other people? If people want to raise their hand, you're very welcome. I don't see any raised hands. Carl, Pauline, did you want to add any other comments or things that I may have missed?
Oh no, you explained very well, Rich. Everything was very interesting. So yeah.
Thank you. For patients who can't afford osteopathy, are there any kind of home exercises we can suggest? From MJ. It is challenging to perform manual therapy on your own abdomen without having an assessment because one needs to find out where the restrictions are present and know how much pressure and which direction to apply. I don't know of any home care other than, I lied. There are some resources that are available that do show some improvement. They tend to be in the mobility area of home exercise. So yoga, there is yoga with restorative function or yoga with restorative balls. Some positions that patients benefit from are yoga where a ball is placed between the upper thigh and the abdomen, and patients will kneel and fold into the ball, bringing their chest towards their knees. It's not always initially comfortable, but it does tend to provide some release of fascia. It's not as specific as, say, the care that you would receive if it was a manual therapy for that organ, but it does seem to show improvement, and that would be restorative yoga with some form of an implement. Some patients will use a gentle fist or a fist wrapped in a towel in their upper thigh, and they'll lean onto that area and they'll get a release. I don't know of any resources that provide demonstration for that, though. If you were to look up restorative yoga, you might find something, restorative yoga for endometriosis. Another question, are there any weight restrictions to this type of treatment? If someone carries a lot of weight in their midsection, is this still an option for pain relief? Yes, so there is no restrictions on weight. There's no classifications of body size, big or small, that we see that we restrict. Endometriosis does not choose, does not discriminate. It affects people of all different sizes, and our outcomes with treatment are effective with women who are of all sizes. So please, if you're considering that maybe osteopathy might not be effective for you, or you have a concern about size, know that body size or body weight has no implication on treatment outcome. We still do the same kinds of work, and it's still very valid to be assessed. A question from Evie. I think you explained it, but I may have missed it, so I'm sorry for repeating it. What is involved in an osteopathic treatment? What happens? Great question. So much like if you were to see your physician, they would ask you questions like, when did the problem start? How often does it happen? We would do a full history taking in osteopathy. We ask you about your history of medications, whether or not you have an IUD. We ask any previous conditions such as endometriosis, adenomyosis, fibroids, ovarian cysts, any surgeries, any other healthcare practitioners you're seeing. And we perform an assessment, much like you would see in a massage or a physiotherapy office. So you would stand, bend, twist, rotate, reach for your toes. We would do joint-specific tests and assessments, and then we would perform, lying on your back, an abdominal assessment, much like the photos that you'd seen in perhaps you saw them. Some of the test positions are hands on the abdomen near the side of your hip, hands on the abdomen around your belly button. We showed, I think, 5 or 6 different hand positions. Truthfully, there are between 3,000 and 5,000 techniques in osteopathy. Probably 1 to 2,000 of them could impact visceral function. So I'm showing you a very, very tiny component of it, just to give an idea. But there are many, many different hand positions, all of which, of course, only are performed with patient consent. We explain what we're going to do, and we express why we're doing it. We show you the anatomy and how it's related to your symptoms. And then the treatment that's performed is similar to the test position, but we hold the test position and we apply a very specific direction of pressure. I say pressure. Pressure is a big word because a lot of people with these symptoms, they don't like pressure on the abdomen, but it's highly, highly specific direction pressure based on the anatomy of the pelvis. And we like to show the person who's on the table with your own hands, we like to show you what it feels like when we feel an area of density. So we'll show you an area that's soft and supple and mobile, not painful. And then we'll show you the area that we tested that's painful. And many of the patients, I would say 95 of the patients that we treat, will say that they definitely feel a density. And then we treat them, and the after treatment effect of the density is much less. That sometimes happens in 2 minutes. Sometimes that happens in 10 minutes. But usually within one treatment, we see a significant improvement in density. And as we've seen from the research, stiffness and density is not a good thing. We see that reduced stiffness improves symptoms. Commonly, we'll provide a home exercise program, which is given to you in a video format. So we might suggest 2 or 5 different exercises depending on what your assessment shows. And we provide exercises for you. We show them to you, and you get a video format that you can watch them from home and perform them. And we look forward to seeing changes afterwards. Typically, we say that the treatment creates a change in the tissues, and then your home care supports and maintains those tissue changes. I hope I've answered your question there, Evie. If not, please feel free to ask again if I've missed something. Can you assess one more thing? If I have abdominal pain, but I also have long-standing shoulder problems, can you look at more than one thing? So that's a very good question. Yes. So in osteopathy, we do not separate shoulder pain from pelvic pain. We assess the whole body. So patients who present with pelvic pain, endometriosis, low back pain, migraine, and shoulder pain, we take all of it into consideration, as all of it can be interrelated. And we commonly see that if patients are seeing a neurologist for their migraines, a gynecologist for their endometriosis, a physiotherapist for their lower back pain, and then they see an osteopathic manual practitioner, what we try to do is coordinate with healthcare practitioners so that we can better understand what this patient is experiencing from a whole body perspective. And if we see correlations, which are commonly present, we do assess and treat many components at the same time. And we see good outcomes from this approach, that it's a whole body approach. And the collaborative care that we do with other healthcare practitioners is quite important in that approach. So no issues at all. Bring to our attention all of the concerns you have: knee pain, hip pain, back pain, shoulder pain. Please speak freely about all of your symptoms, including those that may be associated with social stigmas, like women's healthcare conditions might have. Anyone with a raised hand, any questions? I don't see anyone in the chat with a raised hand. You're welcome to ask your questions verbally if you wish. It seems I flew through that presentation. It's only 7:51. Lots of time if people have questions. Very good. I'm just going to have a peek at my seminar notes here. So for the physicians on this call, if you have an opportunity to look at the kinds of assessments that we've talked about tonight, just change the slide on the picture there. I know that physicians are a great resource for assessing abdominal pain, pelvic pain. There are some difficulties with zeroing in on pelvic pain on our side. It's helpful to have physician assistants in there to get some imaging if needed. If you are a healthcare practitioner and you have the opportunity to perform these abdominal assessments, in your quadrant test, it looks a lot like your typical quadrant test where you're lying on your back. The patient's lying on their back, I should say. And you would do an upper right, upper left, lower right quadrant test. And in much the same way that we test for appendicitis with the McBurney's point pressure, we're looking for rebound tenderness. I would say that the biggest difference in the assessment in screening for these patients who have abdominal adhesions or pelvic adhesions is that instead of just having a linear downward pressure, looking for rebound tenderness, which results in a stretch of this visceral peritoneum, we're looking for a direction-specific stretch that is associated with tightness in the pelvis, reproduction of symptoms from the patient, and possibly a lumpiness that you might feel that should not be present. And again, if there are patients who have not seen a physician or a gynecologist, it is important that you see a healthcare practitioner, such as a physician or a gynecologist, if you have not yet had a diagnosis. But while you're waiting for a diagnosis, you can get assessed and treated while you're waiting for that specialist care. But if you are a physiotherapist or a naturopathic doctor or massage therapist or a physician on this call and you're looking to screen for this, your usual abdominal quadrant palpation with a slight directional shift or a directional lateral or medial distraction, typically away from the ribs, away from the pelvis, towards the belly button, would be a really good indicator of adhesions in here. So if anyone has any questions, I know we've just put a couple of email addresses for Pauline and Carl in the chat. If you have any questions, you're welcome to email them and they'd be happy to get back to you. Any other questions for us tonight? It's really great to see all these people tuning in tonight. I'm excited. It's great to see the interest in the women's healthcare. And I appreciate all the people who have been on this call and put up with me telling you things that you already know, like screening and symptoms and whatnot. It's very much appreciated. So thank you for your time tonight. I'll give you one more minute or two for last questions. Yeah, you are welcome. Great. So if you do have any patients that you wish to refer, if you wish to self-refer, you are more than welcome to contact our clinic. www.ottawaosteopath.com is our website. We do have a women's health web tab under services, and you are welcome to speak with our reception. Email us at info@ottawaosteopath.com, and we are happy to discuss what your best needs are and match you with the most suitably trained practitioner. So thanks all for your time tonight. It's great to see everyone tuning in for this information, and I hope you found it was helpful tonight. So thanks for tuning in, and I hope you have a good night.